the thyroglossal duct, the lymphoid tissue in thymus, again, is a very good example of how things can undergo atrophy even during our developmental stages, right? The quintessential example of this physiological atrophy during development, if I can give you, is how your fingers and toes develop, right? You know, when our fingers and toes develop, they usually start with this hand bud that we have, right? And then digital rays will go inside, right? And these again will start undergoing atrophy, right? So you see the growth of the hand bud followed by atrophy of these rays, right? Which will give you initially webbed fingers and later on will give you separate different fingers and toes, right? So this again is the classical example of how a negative growth signal during development leads to actual development in that individual, right? The other classic example we know is with thymus, right? Thymus is this large anterior mediastinal organ that is usually present in the kids, right? It is associated with the T cell maturation. But once your immunity is complete, once all your T cells are mature, this thymus will again be getting negative growth signals to undergo atrophy, right? To reach at a point wherein an adult, thymus is a very small remnant of the original organ that was present in that individual, right? Okay. Another very prominent effect is what we see under the influence of hormones, right? Or precisely the absence of hormones, right? Remember, a lot of your hormone dependent tissue requires constant supply of hormones, and therefore when they do not have those hormonal support, the organ will undergo atrophy. The classic example again of this is something that we see in menopause with females and the secondary sexual organs, predominantly the breast changes that we see in a female after menopause, right? Of course, this lack of estrogen or the decrease in the levels of estrogen affects all sexual organs, including the uterus, right? Where the endometrium will again not be undergoing the proliferative stage because of estrogen and therefore will not be undergoing the routine regular menstrual cycles, and therefore the female ends up with menopause, right? All because these hormone dependent tissues which required continuous supply of hormones were not provided with that hormonal support, right? And for that matter, remember, almost all your tissues, right, all your organs require hormones or growth factors for their continual normal functioning, right? And the absence of that hormone or growth factor is a strong negative growth signal that will come for causing atrophy in that particular individual organ. Okay, so these are physiological causes of atrophy. Moving from physiological causes of atrophy to pathological causes of atrophy. Now, pathological causes again can be a number of different ways, right? I have told you one mechanism of how you can give out negative signal, and that is absence of hormones or absence of growth factors, right? The other very prominent mechanism is to reduce the amount of blood supply that goes to the organ. You decrease the blood supply, you decrease the oxygen levels, you decrease the nutrients, and therefore the cell will have, or the tissue will have to undergo atrophy, right? Same, a number of organs requires regular signaling from your body, right? And when you lose out on those signals, you again end up with the absence or with the absence of signals, and therefore end up with atrophy. So pathological atrophy can again occur because of multiple reasons, right? That atrophy again. So this is again another classic example of what happens with the second mechanism that I talked about, of how decrease in blood supply can cause problems, right? So right here you can see the brain of a 30-year-old male patient, right? Compare this 30-year-old brain with another 80-year-old brain of another adult male patient, right? Can you see any starking difference? Yes. You can see how the sulci have gone down, the gyri have deepened, right? Classically showing the discrepancy in the size of the brains, right? Again, we classically call this senile atrophy, right? We classically call this senile atrophy. And senile atrophy, right, again, what very jovially આપણે ગુજરાતીમાં કહીએ ને કે હિન્દીમાં કહીએ ને કે બુઢા સઠિયા ગયા है, right? So that બુઢા સઠિયા ગયા है is nothing but this senile atrophy that the brain has undergone in that elderly, right? This classically again happens because of gradual decrease in blood supply and nutrients to that brain, which again occurs because of atherosclerosis, right? See, again, we know atherosclerosis classically leads to myocardial infarction, but all of those are acute changes, right? All individuals after their first 20s starts mounting these atherosclerotic plaques in majority of their arteries, right? Most prominently their coronaries and their cerebral arteries, right? What this causes in the long run over the decades is the lumen of the artery starts narrowing because of those atherosclerotic plaques. The MI, the myocardial infarction, occurs because of complications that atherosclerotic plaque ruptures and causes thrombosis and embolism and this and that. However, if that atherosclerotic plaque does not complicate and remains as such, it will still cause luminal narrowing. And that luminal narrowing of the arteries over the decades is what causes this classic senile atrophy that we are going to see, right? So this in the brain classically shows you the senile atrophy. This same mechanism in the heart classically gives you the brown atrophy of heart, right? Gives you the classical brown atrophy of heart. Clear? Okay. So these again are the two predominant mechanisms that I have mentioned that lead to a lot of physiological atrophy. Pathological atrophies again can occur because of multiple reasons, right? These pathological atrophies again can be disuse atrophy, ischemic atrophy, similar to senile atrophy, starvation atrophy, endocrine atrophy, neuropathic atrophies, and pressure atrophies, right? Excuse me. We'll pick up the examples of each of these major types of atrophies, right? Starting with disuse atrophy. Starting with starvation atrophy. Starvation atrophy is again something that we see very commonly in individuals who have been undergoing what is known as the protein energy malnutrition, right? This can also happen with patients who have chronic illnesses and malignancies, which undergo the phenomenon known as cachexia, right? Here, what essentially happens is that in starvation, you are not eating properly, so your carbohydrate and your lipid stores are depleted. When your carbohydrates and lipid stores are depleted, we know we will shift to digestion of proteins, right? And these digestion of proteins again predominantly is of non-essential proteins like your skeletal muscle proteins, right? I would not want my neural proteins to be digested. I would not want my cardiac myocyte proteins to be digested because they are essential for my living, right? Homeostasis, don't forget homeostasis, right? So even with less amount of energy, I still want to continue to function. So what do? I start digesting non-essential proteins which may give me mobility, but they are never above your neural and cardiac activity, right? So your skeletal muscles start undergoing atrophy, digesting those proteins so you can still have a little bit of energy so that your brain and your heart continues to function, right? So that is your classical starvation atrophy that we get to see. Ischemic atrophy, I have already mentioned, right? Usually is because of atherosclerosis affecting your brains and your heart, but can also affect organs like your kidney, right? Again, this ischemia is chronic ischemia and not acute ischemia. Remember that, right? And gradually in the long run can cause that same organ like the kidney to undergo atrophy, right? Okay. This is again another example of ischemic atrophy, of how the skin, right, undergoes atrophy because of the same thing. Then we've got disuse atrophy. Disuse atrophy again is something that we primarily see with your skeletal muscles to a large extent, and then some of the organs, right? Again, with skeletal muscles, we know that your skeletal muscles require continuous moving, right? Why? Because that movement causes the normal stretch, right? Activation, and that stretch activation, which is usually gravity assisted, is going to help the muscle function normally, When we have, let's say, fracture of your arm, and we immobilize that limb in the cast for a long amount of time, that activation is usually lost because of the stretch, and that loss of stretch is what causes that particular muscle to undergo busting or undergoes disuse atrophy, right? That is why these days even the orthopedic surgeons, after the first 3 weeks, usually tell that the functional movement in that limb needs to be maintained so that that limb or the muscles in that limb don't undergo disuse atrophy, right? Okay, so again, this is what happens. Let's say I have got my normal biceps, right? And because of a fracture in my upper limb, it would have been immobilized in the cast, and that would in the long run cause atrophy of the biceps muscle. Okay. Then we've got neuropathic atrophy, where there is interruption of the nerve supply, right? Now here, this usually happens when you've got nerve dissection, when you've got infections that affect the functionality of your neurons, like your poliomyelitis, or you have autoimmune disorders like motor neuron disease that usually causes the interruption in the nerve supply, and that again is going to cause your skeletal muscles to undergo atrophy. Why? Because these nerve impulses is what keeps your muscles going on, right? And the absence of impulses, because of various reasons, the muscles think that their utility is gone, right? And therefore they start undergoing atrophy. So neuropathic atrophy is again a common mechanism that leads to a lot of wasting of muscles, right? Skeletal muscles. Okay, this is the classic thing that happens with poliomyelitis, right? Because of that excuse me, that infection of the neurons, right? You have this ascending flaccid paralysis because same thing happens with motor neuron diseases. Endocrine atrophy, right? Endocrine atrophy again is where the hormones that are usually required for your normal functioning of various organs do not get their normal hormones, right? Like hypopituitarism, we know, leads to atrophy of the thyroid, adrenal, and the gonads, because the stimulating hormones like TSH, right, come from the pituitary for the activation of the thyroid hormone, right? Same ways, when we have hypothyroidism, we are going to see the skin and adnexal structure atrophy, because again, thyroid hormone is the one that maintains basal metabolic rate by activating the adnexal structures, right? We've got pressure atrophy that usually comes from prolonged pressure from benign tumors or cysts or aneurysm that cause compression and atrophy of the adjoining tissue, right? This is very commonly seen with tumors in the nerve root that cause erosion of the spine, right? Or meningiomas, again causing erosion of the skull, or an aneurysm or aortic aneurysm causing erosion of the sternum, right? All of these are classic examples. So again, though we call them erosion, it's not as if they're eroding, but it is essentially the pressure atrophy of that particular bone because of the continuous compression coming from these tumors, cysts, or aneurysms. Okay, fine, right? And then of course, sometimes we also got idiopathic atrophy where we don't have any obvious cause, right? The classic example is how sometimes people usually undergo atrophy, testicular atrophy, right? Now, a lot of these cases might have a previous incidence of ischemic event, but then there are a number of other other times where these atrophies end up without any obvious cause, right? Okay. When we talk about atrophy, as I've already mentioned, the organ becomes small and is shrunken, right? The atrophic cells will have diminished function and they have become smaller in size, right? So this diminished function again can be picked up by different biochemical tests, right? Like when you don't have enough TSH, your thyroid production of T3, T4 will decrease, right? So that is one mechanism of looking at how hypopituitarism is affecting the thyroid function. But if you look at the biopsy, again, we are going to see that the thyroid follicles have shrunken in size. The amount of colloid has decreased in the size. So that atrophic cell or shrinking of the size is something that is prominent on histopathology or pathological biopsies, right? Now, these pathological changes that we talked about, how are they happening? How is it that your cells are shrinking in size, right? Now see, increase in size is very easy, right? All you have to do is increase the production of particular group of proteins or structural proteins, and you build up the cell's size. Shrinkage is again problematic, right? Because you need to remove portions of your cell, but that again have to be so that the cell can still continue to function, right? And that is where the problem comes in, right? Of how or what are the mechanisms of how atrophy occurs, right? Now this atrophy classically occurs by, of course, catabolism of cell organelles, right? And reducing the cytoplasm of and getting rid of the non-essential organelles, right? So this reduction that we see classically happens by what is known as the formation of autophagic vacuoles, right? These organelles and cytosols will be engulfed by your autophagic vacuoles, and then very similar to phagocytosis, lysosomes will come and attach to these autophagic vacuoles and will cause the degradation, right? This enzymatic degradation will do two things. One, it will eliminate the number of organelles to decrease the cell size, right? But not only that, when you decrease the cell organelles, you're also decreasing your dependence on outside signals. Why? Because now those same degraded organelles, you can digest them and produce a little bit of energy for continuing to function, right? Okay. Whatever is digested will give you the energy. Whatever is not digested properly, essentially a lot of complex lipids cannot be digested completely, and therefore these remain inside that particular cell as a very specific pigment known as lipofuscin, right? This lipofuscin again is also known as the wear and tear pigment, and usually comes up in those organs, right, which have undergone this catabolic activation, right? Okay. This mechanism that we are seeing here, this shrinkage, the formation of autophagic vacuoles, fusion with primary lysosomes, right? This mechanism is known as autophagy, right? Is known as autophagy, right? So in autophagy, again, this is what is basically going to happen. Sorry. So we've got the cytoplasmic organelles. When there is nutrient depletion or there is negative growth signals, the autophagy signal gets activated, which causes this formation of the autophagic vacuole within that particular cell. It encompasses all the non-essential organelles for that particular cell. And then once the autophagic vacuole is formed, it will cause the lysosomes to fuse with this autophagic vacuole and will help in digestion of that particular organelle, right? This degraded, few of them which are not digested, the complex lipids will stay back as lipofuscin. The others will be used in the next step as a source of nutrients, right? And this next step is known as the ubiquitin proteasome pathway. The ubiquitin proteasome pathway, when it gets activated after the autophagy, will cause the activation of ubiquitin ligases and will cause the ubiquitin to be attached to those protein fragments and will complete the digestion of proteins so that these can be used for energy production, right? So this ubiquitin proteasome pathway is what causes the digestion of proteins and excuse me, by proteasome, and causes that digestion, that process of digestion or degradation to be utilized for energy production, right? So this is how cells shrink in size, by autophagy and ubiquitin proteasome pathway. Again, remember, it has dual role. One, it wants to decrease the non-essential organelles in that cell, so we can have decrease in cell size, but also utilize the proteins from that non-essential organelles for energy production, right? For energy production. Yeah. Decrease in cell size by autophagy. Decrease in cell number happens by a specific type of cell death known as apoptosis, right? So decrease in cell or loss of cells is done by apoptosis, right? So that is how we lose our cells, right? By the cells undergoing a specific type of cell death that is known as apoptosis. Yeah, okay, fine. So that is how atrophy essentially occurs in individual cells in response to negative growth signals, right? Starting with autophagy, continuing to ubiquitin proteasome pathway, and ending in apoptosis. Yeah, that again brings us back to this group of pathological atrophies, right? Again, quickly summing up, pathological atrophies occur because of disuse atrophy, ischemic atrophy, starvation atrophy, endocrine atrophy, neuropathic, and pressure atrophies. Right? Again, all of these are negative growth signals or loss of signals or loss of blood supply that is going to give you the negative growth signals, and therefore is going to cause one, decrease in cell size and decrease in cell number. Decrease in cell size by autophagy and decrease in cell number by apoptosis. Okay. Moving on to the other type of adaptation that we wanted to talk about, and that is metaplasia. Right? Now, when we talk about metaplasia, again, it is different from the other adaptations that we've seen till date. Right? All the adaptation, hypertrophy or atrophy, the signals directly affect the somatic cells, right? And therefore we see the changes in the somatic cell per se, right? However, in metaplasia, that growth signal that is coming is not directed towards the somatic cells, but is directed to the small population of reserve cells in that particular area, which are known as stem cells, right? Or more precisely, adult stem cells, right? These signals now impact the adult stem cells, and therefore under the influence of this signal, the stem cells behave differently. And instead of giving one type of epithelial cells, will start giving a newer type of epithelial cell, right? This is what metaplasia essentially is. That metaplasia is again a reversible change in which one differentiated cell type, whether it is epithelial or mesenchymal cell, is replaced by another differentiated cell type, which is epithelial or mesenchymal, right? This reversible change again is an adaptive substitution, right? Where one type is replaced by another type, but it is not as if the change is occurring in the differentiated cell type. No, it's not as if the squamous cell is changing itself into columnar cell. No, it is rather that this is because of the change in the stem cells located at that particular place, which causes the stem cells to which were initially giving you, let's say, squamous epithelium, to now shift towards giving you columnar epithelium, right? What we want at the end is cell types which are better able to withstand the adverse environment in that particular condition or in that particular place, right? So the end point that we are getting is actually cells which are better able to manage the change in the external environment, right? Okay. Fine. If I can give you examples of this metaplasia, again, there are different types of metaplasias. We've got metaplasia where squamous metaplasia is shifted to glandular epithelium. The classic example of that is Barrett's esophagus, right? Now, distal esophagus classically is lined by squamous epithelium, right? And individuals who have GERD, right, that is gastroesophageal reflux disease, right, will have constant acid attack in the lower esophagus because of the GERD. Now, squamous epithelium is not very good against this acid attack. So what happens? The stem cells that are located in the distal esophagus will now start producing intestinal type of columnar epithelium, which will have goblet cells, which will produce mucus, right? And that mucus again will form a chemical barrier against that acid reflux, right? So this classical change, shift, is known as intestinal metaplasia, right? Something that we see in the distal esophagus in patients who have got GERD, and this condition is known as Barrett's esophagus, right? This condition is known as Barrett's esophagus. Okay. Another example, if I can have in the reverse type, is where one glandular epithelium is converted to another glandular epithelium. Something that we see in the stomach pylorus of individuals who suffer from H. pylori infection, right? Now, H. pylori classically gives you chronic atrophic gastritis, right? But gradually, because of this H. pylori, what happens is that the stem cells located in the pylorus, instead of producing the stomach mucosa, again shift towards intestinal mucosa, which will have more goblet cells, which will produce more mucus, right? Again, in response to the H. pylori infection, right? So this intestinal metaplasia that we see in your stomach pylorus in H. pylori again is an example of metaplasia. We also see metaplasia from glandular to squamous epithelium, right? Which is classically seen with your main stem bronchus, right? Chronic smokers again classically show you this feature where the glandular epithelium is shifted, or the ciliated columnar epithelium is shifted to squamous epithelium because of this constant attack by that smoke, right? The smoke that the smokers inhale consists of so many chemicals, right? Which again, the ciliated columnar epithelium is not able to mount against, right? And therefore, the cells, the stem cells in that particular, bronchus will now start producing squamous epithelium, causing squamous metaplasia, right? This again, if I can show you, there is this classical shift that we are seeing here. The ciliated columnar epithelium very beautifully is transitioning into this squamous metaplasia in the bronchial epithelium of your smokers, your chronic smokers, right? Okay. So this again is your classic examples of metaplasia. We also see metaplasia in the urinary bladder, right? Where the uroepithelium under the influence of chronic S. hematobium infection, schistosomiasis, right? Again, it's a worm, will cause the transitional epithelium to convert into squamous epithelium or metaplasia. Okay. Connective tissue metaplasia is still a problem, a dichotomy. Whether it exists or not, people are not very sure about, so I'm not taking that up in detail. But again, mechanisms of metaplasia, I've already mentioned that this is something that happens because of the changes in the stem cell or changes in the gene expression of your stem cells, right? Where under normal physiological conditions, they are restricted to only one type of epithelium, but under the influence of that pathologic stimuli, right, that restriction is lost and changed, and you get a new set of epithelium in that particular area, right? Okay. So that reprogramming of the stem cells occurs because of that particular stimuli that causes a different pattern of gene expression, and therefore you end up having a new type of epithelium in that particular area. Right? So that is your metaplasia for you guys, right? I think that sums or that completes our discussion of metaplasia, right? Quickly to sum up the four major types of adaptations that we've had, right? We could have a quick small little animation, but this is what it looks like. You've got your normal cell, right? This normal cell, again, under positive growth signals, if it has the ability to divide, if it does not have the ability to divide, will increase in size and give you hypertrophy, right? But if it does have the ability to divide, will undergo cell division and give you hyperplasia, right? This, again, if it is given the negative signal, right, is going to give you atrophy, which is initially decrease in cell size, but later we can also see decrease in cell numbers, where it completely the cell is gone, right? And under specific conditions, we will see the change in the phenotype of the cell, right? And it will undergo what is known as the typical metaplasia, right? Where one cell type is replaced by another cell type that we have. Okay, so these are your adaptations in a nutshell, right? Okay, I think that sums up the discussion that we wanted to have for cellular adaptations. Do we have any queries? We can quickly pick up on those queries and discuss them if required.